kind of falls into the realm of rheumatology. Once again, it is a neuropathy. It will cause joint pain. I always say that before I begin every slide because that's our common denominator here. What is the underlying problem? Well, it's this disease is defined or is associated with an infectious agent, and this infectious agent happens to be a tick, small hard body tick, and Borborella is the underlying cause. Okay, so there's a lot of indications or a lot of manifestations that come from this disease process. You can have just simply a skin rash, you can have neurological involvement, you can have joint pain, and so forth. That's the reason why it falls into our rheumatology class, because you could have joint pain. Now, is it the joint pain that you just need to focus in on? No. It is a skin manifestation on the exam that will go ahead and come up. Now, what I mean by that is this. You're not going to have a rheumatology section just for Lyme's disease. They won't do it that way. This is going to be a higher point question. You'll have neurological symptoms involved, so it'll be a neurology question. You'll have skin manifestation, so it'll definitely be a dermatology question. And then musculoskeletal / rheumatology. Therefore, this is a higher point question, so it's guaranteed to be on the exam. It's always on the exam. There's always about 2 or 3 questions about Lyme's disease that are on the exam. Now the question comes into place: what are they going to ask you, right? Well, let's kind of break down the case vignette. Well, just some epidemiology so you guys know, because sometimes they'll say this to you. They'll say, hey, you are practicing medicine in the Northeast someplace or someplace in California, or they might say California region, or somewhere in Northeast, New York, Connecticut, and so forth and so forth. Usually the minute they start saying that, you start narrowing down your question. No one should ask you, hey, you're sitting in an area in Connecticut, New York, and you're like, well, how many other diseases are in Connecticut, New York? Well, this happens to be one of the main ones. And on my boards, they had mentioned this, so I was way ahead of the game already. So 1979, all of a sudden, you have tons and tons of kids that are ending up at the hospital. And they're all complaining of all kinds of issues. Everything's hurting them. They have these rashes that they can't figure out. And alongside with that, some were coming with neurological problems. They were not acting like themselves. And this took headlines all over the country saying, what is going on here? So CDC, when they step in, they kind of really narrow in on things. And that's the reason why this is so important. So 1979, all these kids started to have all these problems. And what actually started to happen was these kids were roughly in the age between 15 to the mid-20s. And the problems began between May and November. The reason why is between May and November is when the weather's really, really nice. So these kids end up at the hospital, and they all have these very weird rashes that are presenting. And these are the rashes that are coming up. So CDC goes in there and said, wait, what's going on here? The disease really picked up from Lyme's, Connecticut. Okay, that's the reason why the name of the town is called Lyme, and everybody ended up in the emergency room. And therefore, they named the disease according to that town. Now, you can see this if you ever go to like Mohegan Sun, or you're on your way driving to Boston and so forth. You'll see big signs out there say Lyme's, Connecticut. And that's where exactly all this comes from. So these kids go to the ER, and they're presenting with these very unique rashes. Now, this is not the gold standard, but the hallmark of this disease, because most of the time, this is what presents first. Not always, but 90% of the time, you have this very unique rash that comes about. This rash comes up within several days to months after the initial inoculation, meaning after you initially get bit. And then what does this disease, this rash really look like? Now, at times, they'll give you a picture of it. Other times, they'll describe the rash to you. Small erythematous macules or papules, okay, around the site of the bite. And then they'll say 15 centimeters diameter with central clearing and induration. Every time I look at boards, they always give you this. That's the reason why it's underlined and highlighted and bolded for you guys. So please keep that in mind. Patient comes in, presents with this rash that presents like a central clearing with induration. And it's non-pruritic, meaning it's not itchy at all. What does it look like? Kind of looks like this. It looks like a bullseye lesion. Usually stands out. My question to you is, well, what other rashes somewhat present like this? Does anybody know? There's only two. Either Lyme or anybody a wrestler here? What's that?
Ringworm.
Ringworm. Okay, so ringworm will start presenting like this initially. That turns into a problem because the way you treat ringworm is completely different than the way you treat this. One is a bacterial agent, one is a fungal agent. The problem is you'll hear this over and over again from practitioners, and I think it's bad to hear this. If it's wet, dry it. If it's dry, make it wet, and everything will get better. That's what most dermatologists will tell. Not dermatologists. Some practitioners will tell you that. In this case, it's wrong. And if you can't figure it out, throw them on some steroids, right? That's what they say. Well, this is a bacterial agent. You start giving steroids to this, and you're going to make this very, very worse. So please do not give steroid to someone who has Lyme disease. So how do they present alongside with this rash? Well, they'll come in complaining of headaches, chills, fevers. And then if it gets to that point, they'll have joint pain. Now, some people will say, well, what point do you get joint pain? Do you get bit and 3 days later you get joint pain? No. You get bit, the first thing will come up is this rash. If the rash doesn't come up, that means you weren't treated right. Because the minute the rash comes up, people end up in the emergency room, or they end up in the doctor's office and they get treated right away. So if the rash doesn't present, then they'll start moving on to arthritic pain. Several weeks, up to years, and then all of a sudden they'll start having this initial presentation of joint pain all over the body. 60% of these Lyme disease patients will develop arthritis if they're not treated. If they're not treated. So you can kind of bypass that. You can not have a rash. Then fall into that 40% region where you don't have joint pain, and they'll go on to neurological problems. You get the idea? So if it's not treated and they don't present, they'll just keep on escalating. But rash, treat. No rash, joint pain, treat. No joint pain, no rash, then neurological symptoms, and then you're probably going to be treated. But we get the idea. Okay, so when the joint pain does come, most of the time these patients will complain of knee pain, real severe knee pain. Okay, and then it gets to the point where they're having a hard time walking, they get really, really stiff and so forth. And then even if that does not get involved, okay, no joint pain, then they can have cardiac involvement. So 8% of these patients will progress to cardiac involvement. Well, they have cardiomyopathy, heart blocks, abnormal heart blocks, and they'll start getting EKG changes, non-specific. Sometimes second-degree blocks, third-degree blocks, and so forth. Usually first-degree blocks are very benign. Somebody, or probably at least 2 or 3 of you guys sitting here, are probably in first-degree heart block right now and not even know it. Okay, because it happens. You could be on Claritin, you could have sleep apnea, the way you breathe, and so forth. Nothing wrong. But second-degree heart block is when things start really coming into place. And the third-degree heart block is malignant heart block. So these patients can have cardiac involvement. We tend to start seeing heart blocks. All right. If that's still not enough, we're still moving along, the patient still hasn't been treated, then we're thinking about neurological involvement. And usually 15% of these patients end up having neurological involvement. Now, when you say 15%, what do you mean? Well, 15% out of that 85 have already been treated, but 15% usually kind of skate through everything and they end up in the neurological involvement. So these patients will come in complaining of some vague complaints. They'll have Bell's palsy. They'll have demyelinating encephalopathy, and those are easily picked up. And then we start working them up. Now, this is a very, very important slide. You should know it, especially if you're going to be practicing medicine here in the northeastern area. These are different stages, and when you get to that point, they have to be staged accordingly. So stage 1, obviously you see that between 3 to 4 weeks, you have that erythema migraine rash, and then we move along and you might have some symptoms of joint pain. Then stage 2, obviously things start changing, cardiac, neurological involvement, and joint pain. And then stage 3, which is usually months and months, where you have severe neurological complications alongside with arthritis. Now, the reason why this is on here is because, look, you see arthritis stage 3, okay? Arthritis stage 2, arthritis stage 1. Joint pains can happen in all stages. Therefore, it has to be discussed not only in rheumatology, But in dermatology and neurology and so forth, you'll see this constantly coming up over and over and over again because it is huge. Okay? You will treat patients with Lyme disease. You will treat patients with Lyme disease. So, how do you diagnose these patients? Well, history, physical is key. If that's not enough, then you can go ahead and do other tests. Blood work can show it to you. CSF is what? Cerebral spinal fluid. If there's neurological involvement, then they will go ahead and get what? Lumbar puncture on the patient. You get a lumbar puncture, and you'll see elevated proteins and so forth and so forth. Okay? Skin biopsy is another way of doing it. If you're unable, if you're unsure and say, hey, I still can't figure out this skin rash that they have, well, you can scrape some of that skin off, do a punch biopsy and send it out. And that will show you, will demonstrate spirochetes, and that will indicate that, yes, the patient has Lyme disease. Now, let's look at the overall picture. If you get bit by a tick, will you always get Lyme disease? The answer is no. It depends on if that tick is infected or not. If that tick is infected, there's a chance that you might still have it, depending on how long it's been sitting on your body and so forth. Some people say, well, I don't know if I'm going to have it or not. I have 4 ticks on me. I'm going to pull them off and I'm going to roll the dice. Correct. There's a chance you might get it. A chance might not get it. Some people will say, well, I was only bitten. It was only there for like maybe 3 hours. That means that's not long enough, so I'm not going to get it. No, that's not so the case. Okay? It depends on if the tick is infected and then how immune your body is. There's a lot of factors that play a part. So there is no such thing as, oh, it's only been on there for an hour. Oh, it's been over an hour, I'm going to get it. No. You get the idea. So how do you treat these patients? Well, the earlier you recognize it, the better it is, and you should start the patient on medication right away. And usually the drug of choice is doxycycline. Okay? If the patient's allergic to doxycycline, then penicillin, like amoxicillin, will work, or clarithromycin will work. Now, on your board, if they do ask you this, they will always ask you for a treatment option, and they'll always tell you the patient's allergic to doxycycline. And then you're going to start wondering all over the place. So just know what's going on here. Doxy is the first choice. If that's not going to work, I'm going to go to amoxicillin. If that doesn't work, I'm going to go to my third choice. On my board, every time I've taken my board, the question's always been, patient's always allergic to doxycycline. And at that point, I started giggling. I'm like, it's always the same thing. It seems like sometimes they recycle questions. And if you're in this game long enough, it's always the same questions over. All right, let's go back to other things. Neurological symptoms. Obviously, you want to go and get a lumbar puncture on these patients and then treat the patient accordingly. And then there's cardiac involvement. If there's cardiac involvement and if there is neurological involvement, then just PO antibiotics will not work. The patient's going to be at the hospital for a little bit, and they're going to need to get IV therapy to move along. Okay, IV therapy to move along. Once again, 4 weeks of therapy if there's meningitis. If it's severe arthritis, then at least 4 weeks or maybe up to 6 weeks, they'll go ahead and treat the patient with antibiotics. But the earlier you grab it, easier to secure. Now, the next question comes into place is, well, I've been in medicine. I've seen patients treat for once. Some get treated for 5 days. Some get treated for 7 days and so forth. Now, there's a new recommendation that just came out recently. I'm going to find out, and I'm going to let you guys know, but it's not going to be on my exam, so you have nothing to worry about. There's different treatment regimens. Some doctors will treat it for 14 days. Some will treat it for less and so forth. So the amount and the duration of treatment, you don't have to worry about. But you do need to know certain things. Okay? Some patients will come to you and say, I don't want to be put on antibiotics. What's my other options? So I want you to think clinically. If someone comes in and has 4 ticks on them, you pull the ticks out, and that patient says, I don't want to be on antibiotics. What are my other options? What might your options be? Just think outside of the box. Okay?
Would you, like, if they don't have antibiotics, would you just give them medications for symptoms that they do have, like if they have joint pain?
Let's say somebody comes in, there's no rash, there's nothing. He's like, I woke up this morning, last night I was out mowing my fence and so forth, mowing my yard. Mowing my yard, and I saw 2 ticks. I woke up this morning, my wife saw them. I don't want to be on antibiotics, bro. I hate antibiotics. It doesn't work for my lifestyle. What do you do?
Wait to test them.
Good. Let's go back to the previous slide. So how do you diagnose these patients? Well, there are blood work that you can do. There is something called IgG, IgM antibodies. And you can go ahead and get the blood work and it comes back. If it comes back positive, then you have it. Normally you get the IgG, IgM, and the lab will automatically say, hey, if these come back positive, then we're automatically going to do something called ELISA and Western blot. And we're going to do that to confirm that this is accurate. Does that make sense? So some patients will say, nope, not getting any antibiotics. What I want you to do is just get some blood work on me. If the blood work comes back positive, then I'll start antibiotics. Get the idea? Any other options? Think outside the box. Start thinking clinically. In a few months, you guys are going to be out there working. I want you to think clinically, please.
Can you like send the tick out for?
Good. Yeah, some people say, I don't care. I have all the money in the world. Send the tick out. I'll pay for it. And I'll tell them, you know what? The insurance is not going to pay for it. We have insurance on you, not on the tick. Kind of like what's going on, right? They say, I don't really care. Well, it's going to cost you $180 to get each tick checked. Not a problem at all. There's 6 ticks in there. I'll write the check. No problem at all. You'll send that to a special lab. The lab will check it out immediately and say, yo, one of them was positive. And then what you can do is what? And you come back to this screen. All right, well, the tick's positive. Do you want to skip the blood work? Just straight go to the antibiotics? Or you want to get tested and see if they do come back positive and then treat it. Get the idea? I want you to think outside of the box. That's the whole point of this game right now. It's up to you how you proceed. Yes, sir.
When do you start treating? As soon as suspected or as soon as positive?
Well, it depends. You won't. So what I normally do is this. I normally tell patients, listen, you have 2 options. One is I can give you antibiotics here, and we don't need to go through all that route. If you're all for it, we can do that. If you don't want to take antibiotics, let's get some blood work right now. It's going to come back in a day or 2, and then we can go ahead and treat you. I'll go ahead and prescribe you the antibiotics. If it comes back positive, we'll call you saying, yes, it's positive. Then you go to the pharmacy, pick up the medication, and start taking them.
Is there a risk for like false negatives on the test?
Well, there is. There is a risk for this. It could be. But IgG, IgM, they're antibodies. They're pretty accurate. So if there's positive, then they automatically go to Western blot. But understand, sometimes these will come back positive, and then this will come back negative. If the Western blot, ELISA comes back negative, that means you do not have it. So the false positive and negatives fall here. And then that. Yes.
For the disease progression, that's only if they're not treated.
Yes.
So at least neurological if they're not treated.
Correct. That's the reason why it's just one of those things like asthma. You treat it and you're good. I mean, that's the reason why it's so popular here. And doxycycline itself, if you ever look at their quarterly or annual calls, the company that makes Doxy, they make most of their living from selling doxycycline for Lyme disease. So big. Fair enough. Questions? How you approach the patient, that's fine. The last thing you want to do is not treat something and let it fall through the cracks because this is a lawsuit just waiting to happen. We had one of our faculty members at Toro about 5 years ago. He was positive for Lyme disease. Honestly, he comes in and then after like a few months, he's just acting different. I mean, different. I'm like, bro, something's wrong, man. You gotta get checked. Something's going on. Just like aggressive and aggravated and like all over the place, walking around, looking around. I'm like, dude, you're like in your 40s. You look like you have Alzheimer's. Short up, got tested. Boom, was Lyme disease. Neurological, was in the hospital for like 2 weeks getting tested. Okay, all right, let's move along. Juvenile rheumatoid arthritis. Well, you're gonna say, well, we spoke about rheumatoid arthritis. Why is it so different? Why is this coming up? Why did we not connect this with rheumatoid arthritis when we initially spoke about it? I didn't want to do that because it gets too complicated and I don't want to get you guys confused. So what we're seeing here is it's a different age group. This is usually between the ages of 16 years of age. Okay, exact etiology of why these young kids get this is kind of unknown, but normally it's young kids who get this juvenile rheumatoid arthritis. Now the question is, well, what's so important about it and why do I need to know and how do I pick this up on the exam? So There are different subsets, which they probably will not ask you on the boards or my exam. The systemic, there's one joint and multiple joints are involved, and there is a correlation with B27. So remember that antigen that we spoke about for spondyloneuropathies, all four of them? Well, it kind of overlaps with that. So please keep that in mind. But is that what the exam questions are going to ask you? And the answer is no. They will probably never bring this up. But what they will bring up and what you do need to know is other things. You do need to know that patients who have still disease, especially they get the systemic form. Okay, but aside from that, what you really need to know is these patients will come in and signs and symptoms that they present with is very unique. These patients will usually come in complaining of a temperature. And it's literally word to word that it's greater than 101. You have a kid that comes in, and the first thing that case vignette says is, this kid comes in, has a temperature greater than 101. You have to say that. They're not going to say 102. That wouldn't work. They will exactly say that it's greater than 101. You know that it's a young kid, 101, or the words, exact words are being used is greater than 101, and then all of a sudden they're having some growth delay, some lymphatic changes, some hepatosplenomegaly, and some weight loss, or any of these things that come into place, you know that we're talking about rheumatoid arthritis. So keep that in mind. Now the next question is, well, is there anything else? Because you might not pick up on this. You might say, well, hepatosplenomegaly, growth delay. You can see that with a lot of kids. It can vary. Well, the temperature 101 might give it away. This might not, but this absolutely will. It will present with a very unique rash. I think there's one or two more rashes that present like this, but they won't kind of say just like this. A salmon-colored rash that's always on the trunk of a young kid who's got a temperature greater than 101, having some weight loss. And we're off to the races. Now, you might say, well, what does that look like? This is what it looks like. You might say that's a terrible picture. Let's zoom in, and that's what it looks like. This right here is the exact picture that was on the boards. So, once again, young kid, greater than 101 temperature, having some fatigue, and then has this salmon-colored rash on the trunk, you know it's juvenile rheumatoid arthritis. Now the question that comes into place is, well, should I see anything else? Because it is rheumatoid arthritis, and you're talking about arthritic problems. Am I looking for arthritic changes? And the answer is yes. What is this showing right here? PIP. What is this? PIP. Is that similar to rheumatoid arthritis? The answer is yes. It is what? Bouchard's notes. And that will ultimately connect it to rheumatoid arthritis. Then ultimately, well, what do? When we diagnose it with a history, the physical examination that we got, now the question is, well, is there any blood work that we could do? Well, some light blood work. RF factors, the complementary factors, you almost might want to get ANA to see if it's not lupus. And then radiologically, there might be something going on, soft tissue swelling and so forth. On the x-rays and so forth, not so much. What's really important here is the signs and symptoms the patient presents with. That's what really gives it away. The labs can vary. Radiological studies can vary. Don't go by those. Go by the physical examination because that's what's going to help you on the exam. Okay, so how do you treat these patients? Well, physical therapy, exercise, Tylenol, NSAIDs, you can give all that stuff. Disease-modifying anti-rheumatic drugs, yes, you could give those to a young person. Absolutely. Can you give steroids? You could if they're IM or if they're what? Methylprednisolone. Then you don't get dexamethasone given to kids. You don't give prednisone to kids. There is a subset of steroids that we do give to kids. Those are oral, but once again, short period of time. Any steroids that you give to any kids can interfere with growth. You do not want that. Your best bet to do is let me start them with some physical therapy. Let me put them with some NSAIDs and so Tylenol. And I'm not going to be doing the DMARDs. I'm going to send them off to a rheumatologist because that's the best thing to do. And you might say, well, why? Because you want to avoid yourself a lawsuit. It always comes down to a lawsuit. Okay? And then when the rheumatologist gets there, the rheumatologist, he or she might decide if they need to go ahead and give any of these. If not, they'll go straight to Enbrel, which is FDA approved and is given for patients who have juvenile rheumatoid arthritis. If the patient fits the category or the criteria, then they will start this medication and we're good to go. Get the idea? Once again, no lab work, no x-rays, it's physical examination, and then they might ask you, what is a medication that's FDA approved? Enbrel is a medication. Okay? All right. You guys want to take a 5-minute break? Yeah. Go right. Next thing, scleroderma. This is the stuff that you see it, you can be like, I feel terrible for this person. Okay? Terrible for this person. I saw a patient about 8 months ago. I don't really practice so much clinical medicine anymore, but I happened to bump into someone and I was answering a few questions and I just couldn't because I just taught this class and I think I just finished off this lecture and I'm looking at this lady and this is a family member and I'm like kind of like looking at her. I'm like, so how are you doing? Is everything okay? Because the person that we were talking about, there was an upper respiratory infection, nothing to worry about. BS. It's fine. I'm looking at the family member and I'm like, are you okay? Like, is everything okay? She's like, yeah, everything's okay. I'm like, all right. She's like, why do you ask? Because I'm like, yeah, just want to make sure. I'm concerned. And she's like, why are you concerned? I'm like, scleroderma? And she's like, yeah, scleroderma. How'd you know? I'm like, typical presentation. She's like, oh, interesting. So with that said, keep that in mind. Let's move forward. Because they all look the same. You'll see. All right, so what is scleroderma? Multi-system disorder where everything breaks down. You have inflammation throughout the body, and tissue fibrosis is really being wrecked. Your body's in there causing havoc. It can start from anywhere, the lungs, the skin, the esophagus, the heart, the kidney. I mean, there isn't a place that this really doesn't affect. It is a multi-system problem, and exactly the cause of it, nobody knows. It's completely unknown. We don't know if there's a trigger. We don't know if there's a genetic predisposition. We don't know any of that stuff. We just know that if you get it, there's nothing we can do to stop it or cure it. We can only halt it, slow it down very slowly. So, what is it? Well, it manifests into something called a CREST syndrome. It really is defined within this CREST syndrome because the physical examination that you see falls under this syndrome. You see, I start getting calcinosis, Raynaud's phenomena, esophageal dysmotility, and so forth and so forth. Okay, so once again, once this syndrome comes into place, it affects every part of the body. You might say, well, what do you mean? Well, calcinosis can affect what? The joints causing pain and so forth. But let's kind of break it down. So we know that affects multiple parts of the body. Let's first talk about the cutaneous involvement, meaning the skin. Initially, this is the hallmark of the disease. So when I looked at the lady, I knew. And then I was able to pick it up right away. So should you, because it's that simple. So what actually starts happening is this. Initially, when this disease starts to move along, you feel like, oh my God, the lotions that I'm using are really working. That Aveeno is really kicking in. That Botox that I got, wow, did an amazing job. None of the above. What's actually slowly starting to happen is your skin is starting to tighten and start to thick underneath. And gives the initial appearance of you're starting to look young. And it really does. But then it starts to getting out of control. You start losing the skin folds within the body. Meaning, if I look at your hand, you know how you have these folds in your hands? Well, they start to disappear. They start to go away. You no longer have fingerprints over a certain period of time. Hair loss because the hair follicles are being what? Choked out. Okay? So keep this in mind, the skin tightening. And this is what it looks like over time. Everything is gone. Now, if this just doesn't happen in the hands, it starts happening in the face. patients who normally have a certain kind of voice will start losing their voice, because if I were to take your face and pull it straight back, you see how my voice changes, right? That's exactly what's happening, very, very, very slowly. And then you start getting thinning all around the face. You almost look like you've been smoking cigarettes. You get those lines on your face. You're like, you always see somebody who's been smoking way too much. You get it. Boom. All right. Then you get something called Raynaud's phenomenon. Now, I'm probably going to put somebody in panic here right now, but I'll come back to it. So what you're having is you have this vasospasm throughout the extremities. Color changes, 3 phases. And it can go from cyanosis to cool, pale, white, blue, red, to red, blue, white, and comes and goes, comes and goes. That could be aggravated by stress, temperature, and or by scleroderma. Now you might say, wait a second, Zeb, I get this. Does that mean I have Crest syndrome? Do I have scleroderma? The answer is no. You can have Raynaud's phenomenon all by itself, or you definitely will have it in scleroderma. Now, remember I said caused by stress, temperature, or by scleroderma. You have scleroderma, you're going to get this. But you might be sitting here all stressed out about Emmett's exam, and everything's changing colors. Okay? There you go. So let's move on to the next syndrome. And this is what you tend to see with, okay, skip it. Here we go. Next one, dilated superficial capillaries. Patients will start saying, oh, I have all these discolorations in my leg. I got to go to the vein center, and they make it all go away with simple injection. Could be. You get it done once, kind of gets better. Within like a few weeks, it all comes back. You have these dilated superficial capillaries, and then within those, it gets hyperpigmented. And that's what you start seeing at the early stages. As far as joint goes, you start getting some calcifications within your joint lines. Underneath your skin, you start getting these balls that start to rise. And these balls are hard. They're not like, you're not able to palpate them well, and they just stick there. And they start protruding through the skin slowly over time. And that causes a joint pain. You tend to see it a lot in the hands, wrists, knees, ankles, and so forth. And it causes a lot of joint pain because of the inflammation. Well, you saw here the superficial dilated capillaries. You saw the fingers and the skin. Here is the skin with these calcifications underneath. Notice how it's starting to protrude through the skin. And they're hard. Then, the next part is esophageal dysmotility. Understand, as humans, we can ask you to eat a full meal, and I can hang you upside down, and you can still digest, because all the muscles and everything. Well, this concept here is what's affected. You have this esophageal dysmotility because even though your gravity's pulling food down, well, guess what? It's not happening. It's not going all the way down. You're constantly feeling like you're full. You're constantly feeling like you have to throw up. You feel like you have acid reflux. The food's not going all the way into your stomach because the sphincters are just incomplete. They're not holding things down. And then all the other stuff, pulmonary fibrosis, restrictive lung disease, because if it's happening in the skins and the fibrotic tissues that are throughout the body, well, they're all along your organs also. So small things will start happening in the lungs. You'll have restrictive lung disease, pulmonary hypertension. Your right ventricles will start functioning not so right. The right side of your heart will start backing up, cause all kinds of issues. And then if that's happening, then patients start going to renal failure because the lungs and the kidneys work. They work hand in hand. Keep that in mind. Okay? And then patients start putting on ACE inhibitors and things of that nature. But let's talk about the history of what they come in presented with. My fingers are killing me. I'm starting to get this little nodule underneath there. My skin looks great though. Even though I have some stuff going on in my fingers, my skin looks really, really good. I went and got this treatment done. My skin's starting to look good. Like, oh, really? Things are really going the other way. Acid reflux. I feel like every time I eat, it just comes back up again. And then after I get out of here, I got to go to the vein doctor. You get the idea? The symptoms all start lining in. All right. Well, I see that some things are problems, so we're gonna go ahead and get some blood work on you. Because, well, why do you need blood work? I thought you'd take my Lanta or something, or Prilosec, that will go away. I'm gonna go to the vein center. I'm just concerned about this nodule sticking out my finger. Just give me an ortho appointment. Well, we'll give you the ortho appointment, but right now I'm gonna go ahead and test you for something else. What are you testing me for? I think you might have scleroderma. Therefore, I'm gonna get some blood work on you because it falls within the Crest syndrome. Oh, okay. Well, first thing first, I'm gonna go get an X-ray to see if those calcifications are there. I'm almost might get an X-ray of the lung to see if there's any restricted lung patterns. I'm gonna get an ANA to make sure you don't have any lupus because it kind of goes hand in hand with lupus. Alongside with that, I definitely want to get something called an anti-SCL 70. This is an antibody that lets us know if you have scleroderma. So I think you do. All the things that you present with indicate that you do. And alongside with that blood work, you know you're having some difficulty breathing. Well, that might turn into an issue later. So I'm going to send you to a pulmonologist, and they're going to do a pulmonary function test to see if you have any kind of restrictive lung pattern. And then last but not least, I'm going to send you to a gastroenterologist. We're going to go and do a swallow eval because you're not swallowing. Eventually, there's going to be no food going down there, and you're going to starve. Get the idea? I'm pointing out every little single thing because I want you to understand the process. Okay, how do you treat this? Well, treatment is not easy. There is no one pill that makes it all go away. It's not going to happen. We're just slowing down the disease process. Depending on what's really bothering you, is we're going to start treating you. If you have Raynaud's phenomenon, no problem at all. We might give you some, ask you to stay out of the temperature, cold weathers, ask you to move down to Florida. I don't know. Okay, nicotine, anything that's going to prevent this vasospasm to happen. Nitroglycerin to help open up, nitroglycerin creams to help open up the vessels. That might help. For the joint pains, NSAIDs, physical therapy, maybe some oral steroids for just for a short period of time. If your skin's getting too tight, no problems at all. I'm going to give you some skin moisturizers. The acid reflux, maybe some antacids, some proton pump inhibitors, the purple pill. I did send you to a nephrologist. They're saying again some kidney issues. We might want to be on ACE inhibitors, and then we move along. You get the idea? It depends on where the problem is, and it's just a multi-system problem, over and over and over again. All right. Now let's take a 5-minute break, and then we only have 20 more slides, and I'll get you guys out. Last few slides are pretty straightforward. Yeah.
Just from example.
No.
That grilled cheese for you.
Yeah, it was so good. I haven't had one in so.
Sometimes it's
It's a heavy meal.
there's butter there too.
I know, but I usually wouldn't do that this way.
Okay, because I don't have the problem.
Which I take.
Is there more plate?
What's that?
It's coming out from our radiology class. I'm taking another one.
Who teaches radiology?
Dr.
Like that?
Yeah, she brings the fun stuff. I'll get later.
So you play with Play-Doh while you guys.
You just get a new one. Yeah. For your exam?
Slides. Study slides. Anything that's bolded, highlighted, underlined.
Can't believe I
It's
see.
stuff-
Someone says it's harder than an F.
Who said that?
Most of them say it's a lot harder.
Yeah, it is. It is. And I'll tell you the reason why, because a lot of people just study from cheat sheets and notes and stuff like that. And they're like, I got an 80. They'll get me in the hallway, start screaming at me. I'm like, well, I don't know what to tell you.
So.
Wait, you said this
As
is
long as we
harder
understand
than
like
now.
Yeah.
Wait,
Well, now lab was like
Now you laugh, now you laugh.
that was the first class we ever had.
Yeah.
Yeah.
It was straightforward because everybody should know the anatomy by now.
Yeah.
But yeah, this stuff you gotta know. So it's all right out of slide. To the point where I had an argument with somebody. I said, listen, I want you to every question that came up that's on the exam, did it come out of your slides? And it was like, oh yeah. I'm like, so then what's the problem? I don't understand. Like,
A lot of these overlap. It's gonna be clear what it is. Like,
oh no, it'll be crystal clear. I'm not here to trick you at all.
Fever of 101.
Yeah.
Greater
Than 101. Greater than 101 with a salmon color rash, you know what's going on. That's a concept. No, I mean that. You gotta know your antigens, right? You gotta need those SCL antigens. You gotta know those. So sometimes I'll put those antigens on there and they're like, I didn't know I could remember the antigens. And I think I told you guys in first class. You gotta know the antigens.
right. So it's both.
Yeah. But then it's fucking screamed in the hallway. I'm like, oh, I don't know what to tell you. Yeah, it's straightforward.
Okay.
No one ever failed.
Wow. So then why do they complain? They just don't like.
Because they got a 78 instead of fucking 98. You know, they're looking at cheat sheet.
Where like they actually like.
They change my exams. I'll put like 15 new questions in every time. And that's what usually gets us. And then we know what I do, you run the crazy thing, it's so funny. It's like you feel like it's comical. So I find out kids are going through the kids are going through well, that's what I mean. I take out their exam and I look to see which questions they got wrong. And it's always the questions that I change. It's always the questions that I change. Like, see, I go in, where is
Yeah.
So I'll tell you back in the day, and actually people still do it. Like they'll get out of class, right? And everybody will meet down the hallway. Like, I have this question. They'll start writing shit down. What? No, then they all I'm just telling you that that's what they think.
Yeah. I think damn it.
No, that travels like Manhattan, it travels like Middletown. You've been for 23 years. And you gotta know.
Oh yeah. Second time I even exam, I feel like I don't.
Yeah.
Everybody got one or two that I know I got wrong, and the rest I don't.
No, but if your job and you plan to do that right when you get out, you'll remember like, so you'll say, the kids will come in and say, listen, you remember the first 5. I'll remember the next 5. You remember that 5. I understand that, but they'll still do it. And then they'll put it all together and go, well, we're gonna see.
Yeah, it's like that's too much. I barely.
I'll tell you the story, which is absolutely crazy. About 7 or 8 years ago, we were at the other campus, we were at the Bayshore campus. And one morning we come in early in the morning, and girls are not able to get into the main door where the PA program is. There's one door that opens up and goes into a big room, and then everybody had their desks like all around those areas, it's a different hallway. Get in, they're like, I can't get it. So it was a girl, Jen, that was brought back then. Jen like text message the group saying, the door's broken, I can't get it. So everybody gets in like 15, 20 minutes later, and everybody's like, what's going on? So we call the janitor comes in, he's like, I don't know what's going on the door. The door is like stuck, the lid on top is completely broken. And somebody's trying to shake the door. They got cameras in it. He's gonna tell you. So like, look at the cameras, they're just finding this thing. And the kids in a program. He gets there like 11:30 at night. He's got tools and shit. And he's fucking trying to unscrew the hinges and everything. And I was thinking to myself, because he's like, he thought the answers, all the answers to all the exam questions were inside. Because at that time, most of the exams were on paper. Like, they weren't on computer. So, and we're looking at the kid, and he's like, got a mask on and shit. Then he takes his mask off and can't breathe. And we're like, is that Bernard? It was Bernard. Like, is that Bernard? Bernard. Bernard's over there, like, I'm taking mask on. And I'm thinking to myself, like, what exam did he have tomorrow? I think he had like a normal. I'm like, spent days and started and studying. Bernard would have passed. Bernard knows. Bernard, like, there's no way. Like, we were all sitting in the room. It was like so comical. And then we put that. We rolled in the TV. You know, so, you remember back then with the TV, there was a VCR there? This year, what, like,
Yeah.
with the play button, and Bernard saying like, you know, like, like, all right, like, no, you're out. Yeah. Then Bernard got his uncle who's a lawyer, uncle's brother's friend, everybody comes down and like, so we actually put red ham, like red. So, I can tell you a million stories about one that's really. We had a student that would take out their phone, plug the phone up, ChatGPT, and take a picture of the thing, and hit the button, ask ChatGPT, answer the question. So, what guys don't know is, you know, when you take your exam, they're watching. I'm very sorry. Like always looking. There's a camera in the room. You're like, what are you doing? I try. I'm up little. I come back down. What are you doing? But that is something.
I think I'll like look up and stuff, and then I'll be like, they're gonna flag.
Yeah.
Alright, let's go. Like I side eyed you, and I was like, I'm like,
I know.
And then we have about 19 more slides. Let's finish strong so you guys can get out of here. And I gotta drive a bus. Who the hell wants to drive a bus? I'm going there for a Yankees game, so that's crazy. Well, the game. Turkey, the USA game.
I should have spent a bet.
So they got
I'm tired.
What's that?
they got the first goal. They were happy.
I turned it off.
Really good game. I just said the World Cup is so much fun this year.
It is.
I don't know why, but it's so much fun. It's like, yeah, it's just it's a lot of fun.
Teams, there's more goals.
All right, so we spoke about every disease process: the cartilage, the synovial joints, tissue fibrosis, to the matrix of the bone from osteoporosis and so forth. And you see the problems could be anywhere in your body. At this point, you're like, wow, is there any part of your body that you kind of get away with? Well, no, not really. Like, if you think about it, you know, you can get like cancer of the heart, right? You probably never heard that. You get cancer of the heart because the cancer comes from where? The muscle. And can muscles get cancer? Yeah, why not? So the same concept applies here. We have muscle inflammation, which is everywhere in the body, and that causes joint pain. So when we have polymyositis, the issue here is this: we have inflammation in the muscle that causes all kinds of issues, and it breaks down the muscle fibers. So if you take a muscle and put it underneath a microscope and you look at it in deep magnification, you'll see that the fibers that normally are supposed to be nice and tight are not. They're literally falling apart. The question comes into place is, what's causing that muscle fibers to fall apart and not stay so tight? Well, the etiology, we don't know. I wish we did, but we don't know. But it's happening. The muscles are being, targeted, and then you have necrosis of that muscle. You have a breakdown of that muscle, causes atrophy, and gets degraded. So then, if that's all the case, and if you look at an overall picture of your body, then what would really be affected? Well, think about it. The muscles that really would be affected are large muscles that carry all the weight. One of those muscles would be obviously the muscles of the legs, right? Muscles of the arms, because you're constantly moving your arms up and down. And then, if that's so the case, that large muscles, well, then how would they present on a physical examination? Well, these patients will come in, and their generalized complaint would be is, when I sit down, I have a hard time getting out of a chair, because you got to use the big muscles in the legs. You have a hard time going up the stairs, and that could be a problem also. And then just generalize putting your arms up and so forth. But what really makes sense is this: you have a lot of weight on your head, which is the cranium and the brain. And the muscles that really do all the work are the what? SCM muscles. And the muscles in your back and so forth that cover your neck. But when those muscles give out, then the neck's going to start flopping down, right? So they'll come in complaining of difficulty lifting their head, difficulty rising from a chair, difficulty climbing stairs. Now, initially, you might say, well, climbing the stairs, they might have congestive heart failure. Well, yeah, but all put together, you can see how the case vignette really comes together. Well, if it's the muscles of all these big areas, then all the tiny muscles will get affected also. Not infected, but affected also. And then respiratory muscles, you start getting dysphagia. You're going to start getting aspiration, some dyspnea, and so forth. And then, just a side note, it's not on your exam, and you're never going to find it on your boards, but there is a very rare involvement of kids who get certain kinds of malignancies that have IMM, certain type of antibodies that they tend to find in children that secondary to polymyositis, they tend to have some kind of malignancies that are involved. I just wanted to kind of bring that up because I read about it a couple of times, a couple of journals, just in case if you're interested, you can kind of read into that. Some rare malignancies that we're starting to find in children. But once again, it's not on your boards and it's not on your exams, but they are associated with polymyositis. So these patients will come in, they'll complain of the underlying problem. You're going to say, well, you know, it's very vague. Anybody can have a hard time getting up out of a chair. Maybe you have muscle strain. Maybe you tore something and so forth. But if you're constantly coming back in over and over again, and I'm thinking after 15 days or 20 days, your muscle should heal. So it's not a strain, it's not a tear or anything like that. We might have to do some other tests on you. So you can get a really indication of what's going on. There are things out there that you can do. Elevated CK creatine kinase, that's usually a first indication is a muscle inflammation that's going on. Remember troponins and CK enzymes for cardiac, right? Well, same concept. You're not going to get the troponins because that's more towards necrosis of the cardiac muscles, or when you have necrotic tissue, that tissue or those enzymes are flowing around. But CK will definitely work. That will tell you. LDH, AST, all these will help, but the antibodies that we really want is anti-JO1 and anti-PL7. These are the ones that really target this polymyositis, and that's what can really tell if that's the underlying problem. Then there's other things that you can do. You can get MRIs on the patients. That will do it and so forth. But normally the way it works is if these come back positive, if these antibodies come back positive, then automatically your rheumatologist or whoever you are, PA, doctor, or whoever the practitioner is, they will move forward with a muscle biopsy. And the first muscle that they'll try to go after is either the muscles in your legs because they're so superficial. If not, they'll get the muscles of the neck. They'll get the SCM muscle. They'll do a simple needle biopsy. They'll go in really quickly, grab a small piece, send it to the lab. The lab will look at it under a microscope and say, whoa, you got a severe breakdown of these muscles. And what they'll do is they'll do multiple sites. It's never one site because you can tear one area. It could be the one area. They won't do it. They'll do one here. They'll do one here. They'll do one somewhere else. At least 3 sites really quickly. And then that will confirm the diagnosis alongside with these antibodies that are there. Okay? So keep that in mind. So the question comes into place, well, how do you treat these patients, right? Well, we treat these patients, the sooner we find it, sooner we can get to it. Because we can prevent that breakdown of the muscle. And the way we do it is this. We give them steroids and high doses of steroids. Okay? That's usually the treatment of choice, and that will bring down the inflammation and halt the disease. It's not going to make it go away, but it'll just slow it down. Alongside with that, the joint pains and the inflammation that comes alongside with it, DMARDs medication seem to work very well. Disease-modifying anti-rheumatic drugs like methotrexate, Imuran, these are 2 that we normally give. But that's not to say that we don't use biological cell modifiers now. Yes, we do. We can give you all the other ones like Enbrel and all the ones that we spoke about. That is an option, but normally we'll start off with these. We'll ask the patient to do rigorous amount of physical therapy because the more physical therapy you do with resistant exercises, the more you're likely to hold on to that muscle without it breaking down too much. So physical therapy is the key. You have to do physical therapy alongside with the pain medications and everything else because that will save the muscle or at least slow down the disease process. It will not. Once again, it will not cure it. So now that we spoke about muscles, let's talk about vessels. Vessels are just as important as everything else. So we talk about muscles. Let's start talking about arteries. Well, this is like lupus, auto antibodies that are fighting your own body off. You have a lot of inflammation within the blood vessels itself. And what I'm talking about are the major vessels, like the large vessels, like polyarteritis nodosa, Werner's, where it hits the lungs. And you're talking about like the aorta and stuff. And then this one we already spoke about, which was giant cell arteritis. So let's talk about the large ones first. Takayasu. These are the vessels that are affected, which are the large vessels, like the aorta. If the aorta is compromised, then the signs and symptoms should be pretty straightforward. Because it's a large vessel, you're going to get headaches, dizziness, claudication. Pulse discrepancy is the number one sign symptom for it. Patient will come in, the pulse and the blood pressure is completely off. When they sit, stand, supine, laying down, whichever way you want, if they're telling you this discrepancy, then you should automatically think about large vessels that are caused by vascular disease, meaning large vessels that are involved. We'll talk about the treatments in a second, but let's start talking about the medium-sized vessels. And we had mentioned this in the previous slide, if you remember. We talked about it in what? PMR. Remember? We said that giant cell arteritis would affect the temporal arteries around the cranium. And they will cause the signs and symptoms we spoke about. We had said that causes what? Scalp tenderness, headaches, unilateral blindness at times, and so forth. And often it can be associated with polymyalgia rheumatica. You can see it here also. Patients who have PMR should also get worked up for vascular issues. You have to go see a vascular doctor. Then we have something called polyarteritis nodosa. These are small to medium-sized vessels. Now, small to medium-sized vessels are everywhere in your body. The question is, are we talking about every one of them? Well, we're not. Okay? You'll see that we're talking about everything else but the lungs. We talk about polyarteritis nodosa. We're talking about all the medium to small-sized vessels, but we're not talking about the lungs because the lungs are completely different, and I'll explain in a second. Okay? So once again, you'll have some manifestations there, possible myocardial infarctions, and things of that nature. But polyarteritis nodosa affects mostly the small to medium-sized vessels, and we find out that hepatitis B antigens or hepatitis B antibodies and so forth really, really affect those areas. Okay? Now, we spoke about all the medium and small-sized vessels. The question comes into place is, well, what about the ones that spare the lungs? Well, the lungs are spared, and they have their complete own category. And that's called Werner's granuloma. Okay? This is simply different. Why is it different? Can anyone tell me? Because in the lungs is the only way, well, the only vessels that are what? Flipped upside down. Your arteries are really veins, and veins are really arteries. Therefore, the category is separate in itself. These are also small to medium-sized vessels. And then, once again, if you have lungs that are involved, then the kidneys are also going to be affected, I apologize. And for those reasons, kidney function tests have to be monitored, BUN, creatinine, and then everything else, GFRs and so forth. These patients will come in. Anybody who has lung issues, we always tend to see a common denominator here. They always have upper respiratory infection, sinus issues, and most importantly, mucosal ulcers. Always, we tend to see that. There is a strong common denomination. Patients who have any kind of lung issues, they will have this ulcers in their noses and the sinus infections and chronic runny noses and so forth. So keep that in mind. All right, so how do you diagnose all these patients? Well, history and physical is the key. Oh, my blood pressures are off. Well, why is your blood pressures off? My pulse is off. Every time I get up, I feel like I'm dizzy. I'm going to pass out. Ooh, well, maybe one of the large vessels, something's going on with it. I'm having some sinus issues constantly. I'm constantly at the pulmonologist. I'm constantly at the urgent care center because I have upper respiratory issues. Well, you shouldn't. Is there a problem with the vessels that are in your the arteries and so forth? You get the idea? That's how you pick it up. And it's not an easy diagnosis. You don't go to primary care doctor and say, oh, yeah, I'm having some sinus issues. Oh, I'm sorry, you have vascularity problems, and therefore you need to go see a vascular. That's not the way it is. You pick it up after a number of, process of exclusion. All right, let's get back to this. If you do have any kind of vascular issues, no matter where it is, there are antibodies that you're able to do, and they're called PANCA and CANCA, PANCA, CANCA. We tend to see this a lot in the pulmonary world. Most of the time, when you go to a pulmonologist, is where you pick up that you're having all these discrepancies with the vascular. So pulmonologists and vascular doctors tend to work very, very, very well together. And then it goes to show you that, wait, vessels can make sense. DVTs, pulmonary emboli, pulmonary issue, and vascular issue. It's so connected. Medicine is so connected, it's not even funny. All right. You get these antibodies, and then, once again, biopsies, and off you go. You might say, well, what do you mean? How do you get a biopsy of the aorta? No, we're not telling you that. We're telling you to get biopsies of superficial, like what? Temporal biopsies. But it's got to be in a controlled environment. You can't be at a primary care office saying, hey, you know what? Today we're going to do a temporal artery biopsy. That's crazy. It's got to be in a structured environment in the hospital setting and so forth. Because you cannot be puncturing arteries, especially around your eyes and so forth. It'll make the patient go blind immediately. And the reason why I say that, you'd be surprised how many primary care doctors do all kinds of weird stuff in their office. They're like, I can do anything. No, you can't do it. Okay? All right. How do you treat all these vascular problems? Well, inflammation is the key. You want to bring down the inflammation, and you got to give them steroids. You got to give them steroids, and once again, it's a high-dose steroids. Okay? That is, I guess, the cornerstone of therapy. Once again, if you're a candidate for steroids, that's fine. Patients are put on weight. If they're diabetic, then they're probably not a good candidate. You get the idea, okay? If they're osteoporotic, if they're osteopenia, it's just going to make things worse. Then disease-modifying anti-rheumatic drugs like methotrexate, Imuran, and cytoxan tends to work very well for these patients who have this underlying problem. Cytoxan works very well with Werner's granuloma also. So please, please, please be careful. You got to send this patient to a pulmonologist. You got to send them to a kidney specialist. You have to send them to a rheumatologist. They all work together with situations like this. It's so, so important. And then understand that it's a vessel. If the vessel is not working properly, then what do? We cut the vessel out, we put a new one in. Same thing like a cardiac bypass. You have 4 vessels that are occluded, not a problem at all. Let's grab some vessels from the feet and put them in there, and we'll bypass it. Okay, so vascular biopsies tend to work very, very well, and vascular doctors love to do that. They're tired of giving medication to a patient forever. Understand that vascular doctors are also surgeons, so they want to take you into the OR. Like, not a problem at all. I'll grab something out of the foot or something, I'll replace it in the heart, and we're ready to go. It's just that simple. Okay? All right, last but not least, and let's get out of here. I want to talk about fibromyalgia. I tend to save this to the last because I always take off somebody, but it's just the facts. Okay, fibromyalgia is a fairly new disease process. It's been out for the last like maybe 8-9 years and so forth. We do know a lot about it now. We didn't know much about it back then, but unfortunately we should label patients with it. We would say that these patients are drug seekers and so forth, but now so much more data is coming up that's completely opposite. So please keep that in mind. Never, ever, ever, ever just judge a book by its cover. Understand and see what these patients are talking about. Do not label patients, or don't label anybody for that fact. So it is a complex problem. We tend to see it all over the place. These patients have psychological issues that are going on, meaning they're usually depressed at times. They have sleep pattern disruptions in the sense that they don't sleep so well. They don't get enough sleep. They have a lot of pain, a lot of myofascial pain, meaning musculoskeletal pain. Once again, the etiology, we don't know, but we're learning more about it. We're thinking that the neurons are firing way too fast in the body, especially in the brain and so forth, and that's causing these underlying issues. So we do know that these patients are normally stressed out. They have a lot of sleep cycle problems, and there's some depression that's typically involved in this underlying problem. The truth is, if I didn't get enough sleep, I would be pretty depressed too. And I think you guys will all agree to it. You need sleep. Okay? And if there's anybody I can ask you guys, because you probably guys get no sleep. I got a lot of sleep. All right. So roughly around 3 million people are affected with this disease process every year. But we do know that they do not have enough REM sleep. And the problem is they have a hard time going to sleep. They have a hard time staying asleep, and we find out that they're early morning awakers. They wake up really early, they have a hard time going to sleep, and then their REM cycle is very, very low. Does anybody know how much REM sleep you should get a night? Roughly around, is that 12 hours, 10 hours?
12 hours.
12 hours? Who said 12? How much REM sleep are you supposed to get?
Just REM.
REM, like deep REM sleep.
2 hours. An hour. Yeah.
It's usually between an hour and like hour and 45 minutes, depending on your body status, your age, and so forth. If you're not even getting good hour and 45 minutes of sleep at night, then we got a huge problem. Now, this is if you're putting in a good 7 hours of sleep, meaning you go to sleep, right? You're not going into REM sleep right away. It takes a while for your body to go into REM sleep. Then you hit REM sleep, and then you come right back out. Okay? So about an hour and a half of really good REM sleep. That's what you really, really need. Okay? So that's what we're talking about. And most of these patients don't get it. That's the reason why Michael Jackson years ago, remember he used to get propofol? He would get like that hour and a half, 2 hours of REM sleep with that and wake up like completely normal. Has anybody ever had any kind of, have you ever been put under?
Yeah.
No one's ever been put under?
That's
You've been put under?
Yeah.
So I'll give you my experience. You guys have to share your experience. I didn't know my biological father, and I didn't know anything about it. So I got to a point in my life where I'm like, I really should get checked out because I don't know if the guy died like when he's 20 or not. Who knows? So I got a colonoscopy. Like, fuck, let's just do it. So I go in there. I was down for like maybe 15 minutes or so. And at that time, when I got colonoscopy, I just had kids. And for those who have kids, you'll know exactly what we're talking about. Like young kids are growing up, getting no sleep. You have a 4-month-old, you don't get any sleep. You don't get no sleep at all. Anybody told you otherwise, lying. So I was like in that time of my life, and I'm like, you know what? I just want to go get a colonoscopy just so I can go to sleep. I swear. I go in there. I was probably put it under for like maybe 8 minutes, 9 minutes, if that. I woke up and I'm like, oh my God, I've never slept like this before. I felt like I was sleeping for like 3 days. And like, like deep sleep when you wake up and you wake up in the morning, like, what the hell happened? It was like that. So can you imagine you getting put under and if you need REM sleep for an hour and a half, you get put under and get deep sleep for like maybe 10 minutes or so forth. So refreshing. I gotta tell you, I felt like I like mow everybody's lawn. I'm like, I'm going home. I got so many things to do. They're like, no, you're gonna be sleeping like 5 hours. I'm like, no, I'm not. I already slept. But you get the idea. So these patients do not get any of that REM sleep at all. Because they don't sleep, they have a hard time falling asleep and they wake up early, that REM sleep pretty much doesn't exist. Alongside with that, joint pains and things of that nature are constantly there. Fatigue, morning stiffness, being called a gel phenomenon, and so forth. But what's crazy about it is this, all the exams come back negative. There's no lab exams, there's no CBC, BMP. Everything comes back negative. Even the ESR, CRP levels are all within normal limits. Okay? X-rays all within normal limits. There's nothing going on. But we do know certain risk factors and what they really do complain about so we can help put the disease process together. We know that they have trigger points, meaning tender points that are throughout the body. And some of them are called, not called, but occipital, lower cervical regions, the trapezius muscles. This is what was on my board. Actually, this is one right here, greater trochanter bilaterally. They have a lot of pain in those regions. And that's how I was able to pick up on fibromyalgia because I don't know any disease process out there unless you broke a hip, but it's got to be bilateral. Greater trochanter bilateral pain. I've never seen that in any disease process. It was there. I was able to pick it up. Alongside with that, no REM sleep, early sleepers, all that good stuff. We find that most of these patients have irritable bowel disease, chronic fatigue syndrome, and then this really always pops up. I still don't understand the etiology of it, but we're still trying to figure it out. We find that these patients have multiple drug allergies. They're allergic to everything that you can imagine. Okay, and mostly certain kinds of pain medications. So, how do we diagnose these patients? Well, history and physical will give you a vague description of what you're looking for, but it is a process of exclusion. You have to get x-rays negative, labs negative, everything comes back negative, and you're only working with the physical examination, which is really not there aside from the point tenderness, and everything else within normal limits, and then it's almost like clinical diagnosis. It's like saying someone has what? Bronchitis. Okay? You don't see bronchitis on an x-ray, it's a clinical diagnosis. Exactly like this. Fibromyalgia tends to be more of a clinical diagnosis. And once again, no studies to get you that gold standard. But treatment varies. Analgesics, NSAIDs will work on some people. Tricyclic antidepressants will help with the depression symptoms. Muscle relaxers, trigger point injections with lidocaine and serapine, that might help, and that will calm the nerves down, therefore at least they can get some sleep. And then physical therapy, maybe tired them out a little, help them go to sleep. Muscle relaxants help, but just recently FDA approved a medication. That medication is called Lyrica. Other times you can also use gabapentin. That will work with the flare-ups, as we mentioned before. We're now starting to sense that it is a neuron issue that are overfiring, and Lyrica or gabapentin seems to kind of control those. We find these patients do very, 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 very well with this. And then we can kind of take them off the pain medications, and everything else starts falling in place. But I'm not saying that you give them Lyrica or gabapentin and everything goes away. That's not so the case. It just kind of improves the symptoms. They still need to be on everything else, but you pick and choose your battles depending on how you want to treat them. Okay, but it's a clinical diagnosis. I'm not sure how much you're going to see this on the boards, but every once in a while it'll pop up. Okay, all right, that's it. Thank you for coming.
Thank you.
No, I'm going to teach more classes, you guys.
Okay, okay.
Oh, yeah.
Yeah, okay. No, one example room. This is the last class, but I'm going to be teaching, I think, endocrinology class last semester. Thank you. Everybody get up safe. Have a safe. Thank you.
Thank you so much, Professor.
Thank you. I appreciate it too. Have a great weekend. I'm sorry. Thank you.